That's
just
what I do.
information.
So there's an outline of stuff. You need to know what these,
Terminology.
what the terminology is. So it's a glossary thing, right? And I think that we've covered them all. Is there anything in there that we haven't talked about in class?
I
don't think so.
recognize pretty much all of them.
Yeah.
Or at least have
So
heard
you
them.
should know what those are, okay? And then the concept stuff is, you have to know what APGAR score is, but you also need to know the components of it, and then why is it useful, okay?
We don't have to remember the score, everything, right? Just
No, you do. I'll describe a patient. The heart rate is this, the respiratory rate is that, the tone looks like this, their response is this, and you have to
Score them.
That's 2 points, this is 1 point, this is 1 point, and add it up, and you need to tell me
So
that
remember
this is a score of 7, right?
everything.
Whatever it
Remember.
is, yeah.
Oh my God. Okay.
Yeah.
Okay.
You need to, that's what I mean. It's not just knowing the meaning of the word, but why, how do I use this clinically? What's the significance of it? Okay.
Okay.
Ballard score is the one that we're looking at, trying to estimate the gestational age. What are the most common? So I'll just give you this one. The most common lab done in neonates is glucose. Okay.
Yeah.
Right. So but others might be APGs and it could be CVGs, right? So think of things like that. What is congenital diaphragmatic hernia? What do you need to know about it? So it's when the intestines are up in the chest. It might make it very difficult to intubate, to ventilate a patient. If you have to ventilate them, do not do mass ventilation because you're going to get air in the belly, which will make it worse. So you intubate them, and hopefully you know this ahead of time.
Okay.
And then stabilize them until they can get surgery to get that removed. And then the other thing that goes with that is the scaphoid abdomen. It's kind of, they're sort of, when there's intestines up in the chest and they're not in the belly, and the belly looks kind of empty. Right? So, continuous albuterol aerosol, why we do it for status asthmaticus and things like that. Hazards of it are that they can get really tachycardic, they can also get really jittery and anxious, and then they can also get hypokalemia, so that's another thing that you need to be aware of. And monitor their potassium before and during. Chest PT, why do we do it? Some of the complications just right out of the lecture, basically. What is ductal dependency, and understanding that term and the significance of it, knowing that a patient has a ductal dependent cardiac lesion. The last thing you want to do is give it excessive oxygen because that might stimulate the ductus to close, right? And you're going to accept that there will be shunting, and the SATs probably maybe only in the 80s, and it's kind of the things that you need to know about that. I can't stress enough, you have to understand the transition from intrauterine circulation to extrauterine. So you got to know where the shunts are, particularly the foraminal valley and the ductus arteriosus, and what causes those things to close normally. There's a whole series of things that
there's a lot about that.
referring to. I'll give you this hint. There's a little bit of short answer stuff. Be prepared to talk about it. Don't.
Okay.
That if that's not a hint.
Is that like in regards to like what is that one called? PDA, pulmonary ductal arteriosis.
Well, I want you to understand what are the mechanisms that cause the changes to happen shortly after birth.
Okay.
So the first thing that happens is the cord is clamped or cut. Okay. That almost instantaneously kicks up the left side pressures because it increases systemic vascular resistance, right? So the left side pressures rise because of the loss of the cord. And then right around the same time, the baby comes out, takes their first breath, the lungs are full of air, right? So that reduces resistance to blood flow into the lungs, right then. So blood starts to flow into the lungs. And then the baby's breathing higher concentrations of oxygen than those lungs have ever seen. And that stimulates vasodilation of the pulmonary vasculature. So the blood vessels that are kind of clamped down and say, don't come here, we don't need blood through the lungs before birth.
Mm-hmm.
When the baby comes out and starts to breathe and there's oxygen, that stimulates those blood vessels to relax and allow blood to flow through.
Mm-hmm.
And that causes a reduction in the right side pressures.
Right.
As that resistance dissipates, the pressures drop.
Mm-hmm.
Okay. And it's that swing in pressure, left side pressure is rising, right side pressure is falling when it closes the foramen ovale. The winds shift and
Right.
blows the door shut, basically.
Gotcha.
Gotta know that. How to assess perfusion? So in kids especially, we're looking at central and distal. So we'll do the skin blanching.
Mm-hmm.
Is it pink up in 3 seconds or less? But we got to look central in the core versus peripheral, like on a knee or something, right? Because they may be different. And if it's slightly delayed on the knee, but it's good in the core, we're good,
Right.
right? But if it's delayed both places, then we got issues.
Mm-hmm.
Thumb sign and steeple sign, we talked about assessing croup and epiglottitis, and so you should know which is associated with which. The steeple sign is associated with croup. The thumb sign is a big engorged epiglottis that looks like a thumb on the X-ray, and I guess maybe which is the more severe emergency? Is croup worse or is epiglottitis worse?
Epiglottitis?
Epiglottitis is a true emergency. Croup is kind of a nuisance. Usually. Can be an emergency, but it's often not. O2 hoods, advantages and disadvantages. Advantage, steady FiO2 delivery, right? So you put it on 40%, if you have sufficient flow in that hood, you know the patient's getting 40%. Or nowadays, we pretty much just use it for 100%. The disadvantages is it's kind of a pain in the butt. They can get heated up in there. It's sort of hard to access their head. And there's a layering of the oxygen, and so you can't assume that it's the same FiO2 at the top of the hood as it is at the bottom and stuff like that. Significance of the OB and maternal history. So like if I told you 10 hours before delivery, the mom had a fever of 102. What difference does that make? Why did? So maternal fever implies maternal infection, which means perhaps the baby can be infected. So that's a risk of sepsis with maternal fever. Abruptio placenta, so risk of hypovolemia, blood loss, anemia, etc. Okay. Mom had gestational diabetes. Risk that the baby will have some glucose instability, as well as probably being large for gestational age and kind of fat and lazy. My words, not the book's words, but I mean they tend to be chubby and they're kind of underdeveloped. Okay. So there's more examples, so I'm not going to go through them all, but if you read, so there'll be a little scenario, say this is the history, and the question might be, what does this history suggest the baby could be at risk at? If there was fever, maternal fever, then it's a risk for sepsis. IDM or gestational diabetes, risk for an LGA baby and immature lungs. Abruption, risk for anemia and hypovolemia, things like that. O2 titration in neonates, we do not want SATs greater than 95, which is kind of standard operating procedure in the adult world. But in the NICU, it's usually like 88 to 94 is the range that we're looking for. So you should know that.
Mhm.
What's the appropriate ranges. Neonatal vitals, you should know that, babies, well, you set the low heart rate alarms at 100. So, 60 to 100 is not normal for newborns. 120 to 160 is probably more normal. The different people will give you different ranges. But yeah, 140 is common. I don't even get excited about 180, especially on a preemie. That's normal. So things like that. Kind of getting back to the, kind of already talked about it, but identify newborn risk from maternal history, so we talked about that already. What are initial ventilation strategies? So what did I teach you to start bagging and giving the ventilation to a baby?
It's every
Pressures.
pressures. Keep a 5, PIP 12, I think. No, more.
20 over 5 or so.
20 over 5.
20 to 25 PIPs with peeps of 5 to 8.
Okay.
But I think the classic starting point for most situations is where you don't know anything else and you're attending to a delivery, set your T-piece resuscitator, your NeoPuff up for 20 over 5 pressures.
Okay.
That's a good starting point. So just know that. How to deliver aerosol meds to neonates, infants, and children. So older kids can use mouthpieces, infants and children. Blow-by is not acceptable. You really need to hold the mask close over their nose and mouth. Try to calm them down, because if they're screaming and holding their breath and all that, that's not a good way to deliver it. But whenever possible, use a mouthpiece and encourage them to breathe through their mouth if they are wearing a mask. Pre and post-ductal oxygenation. So what does it mean, pre and post-ductal? And then where if I drew a blood gas, let's say I draw an ABG from the baby's left foot, is that pre or post-ductal? It's not a trick question.
That would be post-ductal.
It is. Essentially, I mean, the way to remember this is if it's from the right arm, it's pre. Everywhere else is post. So if I draw a blood gas from the right arm or the right hand, it's a preductal. Or if I have a pulse ox on the right arm or the wrist or hand or something, that's preductal. Every other site would be considered postductal. In theory, the left arm can be what's called juxtaductal, and maybe it's a little bit of both. But we're just if you want preductal, it has to be on the right arm. So anywhere else but right arm is postductal.
Right is right.
Yeah. What is the SPAG? What does it stand for? What is it used for? So it stands for small particle aerosol generator, and it's used to nebulize a special kind of med called ribavirin, which is used to treat RSV, or I would say was used, because it's almost never used anymore, but in theory it's still. It's still in the test. I don't know why. I don't know who the hell does it. Nobody in Hawaii does it, that's for sure. And then ribavirin, what is it and why, and when, why? So to treat RSV, it's usually done for like 5 to 7 days, so period. Alternatives, Synagis. Synagis is why we don't use ribavirin anymore. Speaking of Synagis, who, why, and how is it given? And so remember those. There was a special kind of mini lecture on Synagis and who qualifies for it. The general rule is if they were born very preemie and leading up to the RSV season, they should be treated. If they're not quite as preemie, but they're close to the season, they should be treated. And if they're more term kids, but they have congenital, especially heart and lung problems, they would be treated. And the other other issue is if they have siblings that are going to and from daycare and they're swapping snot with the other kids and then they bring it home. The word swapping snot won't be in the test. Relative advantages of different bags and the NeoPuff or NeoPip
Right.
device. So flow inflating and T-piece resuscitator are 3-in-1 tools. They can do free flow oxygen, they can do CPAP, and they can ventilate. Whereas the self-inflating bag, your traditional Ambu bag, can really only ventilate. It really can't do the other stuff that you might want it to do. So that's why they use the flow inflating bag lining, because it meets all our needs in one tool, which is kind of convenient. But if it doesn't have flow, it will not work. It must have flow for it to work. So you keep the Ambu bags around in case you don't have flow. At least you can ventilate. Kind of already talked about layering of O2 in hoods and tents, but there's a question on that. The stages of labor, we just covered that in the last class. Stages 1, 2, and 3, which is the longest stage. Stage 1 usually drags on for hours. Stage 2 is when the appearance of the baby comes, and stage 3 is the aftermath and after birth and stuff like that. And then basic resuscitation procedures. This is the thing that I realized I was going to show you a video on Tuesday. So that might not be on this test because I didn't really cover it yet. But I got to look and see. It is somewhat covered in the book. So I'll read the question or two and see if
Is
it's
it
appropriate.
is it in our slides?
Not really.
Okay.
No, it would be in the book. But the general rule is whenever a baby comes out, the first thing you do is dry and stimulate. Because remember, if they're wet, cold stress is the worst thing for a newborn baby, right? Well, not the worst thing, but it's a bad thing. So we're drying them off to get all the wet stuff off because that would lead to evaporative heat loss. And that's going to make them cold. It's like, that's why, sometimes when you're in a pool up to your neck and it feels, and then when you get out of the pool, it feels colder when you're out of the pool. It's because you're not, you're immersed in this and it's not evaporating away from your body. But when you get out and the wind blows, it pulls the heat away much quicker. That's why it seems colder outside. So we dry and stimulate, and most of the time that's all you have to do to a term newborn. Dry them, kind of rub them a little, and get them going, and they start breathing, and they're off, and they don't stop for 80 or 90 years, right? But if they're having a little bit of a slower time, then you do that first, and if that isn't cutting it, and their heart rate is low, and they're not breathing, then you start to ventilate them. And most of the time, just a little stimulation and a few quick breaths, and they start breathing, and they kind of wake up, and their brain's getting some oxygen, and then you can't shut them up, right? So that's all you need to do. So those are the initial steps, and that's basically what we're looking at. But I'll look and see what's in the book and how the question is written.
And that's regarding that last point right there.
So, and then the other thing is there's a couple of scenarios. So the two scenarios, these are like clinical simulation sort of things. So there's a little history given, some information about the patient, and then there's 3 or 4 questions based on that scenario. So, and then there'll be 3 kinds of possible questions. So there's some kind of recall question, like this baby is being born to a G3 mom. What does G3 mean, right? So that's a recall question. I taught you that, and it's just you either know it or you don't. Okay. And then analysis questions are: there's a situation, what medication might be indicated for that situation? Okay, so the child is wheezing, what med would you give? Albuterol. It's not that question, but I think it's a question like that. Okay.
Right.
And then So that's an analysis question. And then application is select the correct oxygen strategy and equipment for treating the problem. So given this situation, how would you administer O2 and how much, and what concentration to this baby or this patient, wherever it is? So that's a little more complicated question. You have to take some information, do some analysis, and then fix the problem. Okay? So that's the most difficult con. Okay? So there's 50 points. There's I might adjust this. So last year there was just one short answer question about just a few sentences. You don't have to write a small book, just this much.
Okay.
But I might wind up giving you a little less multiple choice and 2 short answer kind of questions instead. But that's basically the gist of it.
And we can practice like this kind of clinical
So
simulation.
just make sure over the weekend, and I'll send you an updated version of this by this afternoon. But make sure you can answer. You know what all these words mean, and and then understand the concepts. You can't just know what the word means, but why is it significant? Why did I teach you this? What's important about it? Okay.
Got it.
That's it.
Thank you.
It shouldn't be a terribly difficult test, but I know you guys worry yourselves over things.
Yeah. Wow, a lot.
No, we got it. We'll study this weekend.
I did with my phone.
Where is this?
Oh.
I sent to you.
Oh, I recorded.
Oh, you did?
Mm.